Good morning, everyone. Thank you, organizers, for inviting me and giving me this opportunity. I thought my work has been made a lot easier. A lot of discussion has already been there on insulin pumps, the benefits, indications, etc. I thought I'll just add the Indian spice to it. But unfortunately, India being famous for spices, but not for pumps. So we have to do a lot of work in the field of insulin pumps if we want our kids with type 1 diabetes to use these pumps. So in next 15 minutes, I would be covering first about the standard recommendations regarding insulin pumps in children, which again has been dealt with earlier. Second, I would be discussing about the indications, particularly in the Indian settings, where and how we could advise or prescribe insulin pumps. So to begin with, the insulin pumps are actually a good mode of giving insulin therapy, but what we have to see is whether it is helping in glycemic control. Obviously, insulin pens are better than insulin syringes. Similarly, insulin pump is better than insulin pumps in giving insulin in these kids. However, what we have to see is whether glycemic control is good or not. So, declaring my conflict of interest. This is the outline I was talking about. So, I would be stressing more on obviously the Indian scenario, the challenges of insulin pump therapy in Indian context, the strategies how we can optimally use this costly treatment. Our experience, I'll be briefly discussing of around 34 patients, and then I would be suggesting an inpatient pump initiation protocol if time permits. So coming to standard recommendations, ISPAE 2018 guidelines on diabetes technologies in these children clearly states that sensor-augmented pump therapy is superior in children and adolescents over MDI with SMBG in reducing HbA1c. The two words here are quite critical, that is sensor and augmented. Sensor-augmented pump therapy is obviously important. It's not just insulin pump. It has to be supplemented with CGM. And that CGM has to be on at least 60% of the times to achieve good glycemic control. That's another important point. And low glucose suspense systems, which obviously work with sensors, has a significant reduction in hypoglycemia without increasing any glycemia, without deteriorating glycemic control. For preschool children, which has already been told that children less than 7 years, insulin pump should be the preferred or first choice mode of giving insulin, and MDI should be advised only if pump option is not there, for various reasons actually. Coming to indications, all this has been discussed. ISPAE has divided into two groups, the indications where the pump could be considered, and another group where pump is actually beneficial. Here I would say that for Indian scenario, as the pump is being financed by the family itself, and they don't have any insurance, or government is not providing pump, so it's individual choice, and any patient actually will fit into one of these indications, which is the long list of indications of starting insulin pump therapy, and is not happy with MDI and can afford pump. I think we cannot deny or not write or prescribe insulin pump to that patient. So coming to insulin pump uses in the Western setup. This is very latest study from SWEET registry, data from SWEET registry. This is actually data from 29 countries, 24 who are part of the SWEET consortium. And they have shown that there is persistent heterogeneity in diabetes technology reimbursement, including pumps and CGM, within the Europe itself. So they compared this data. In this slide, this green is where the pump is freely available. Red is the area or countries where pump is not available, and yellow where it is available with some limitations. So they have seen that there is significant increase over last 7 to 8 years in use of pumps. And many countries who were earlier red have turned green, given a green signal for the use of insulin pump reimbursement. This is use of CGM over time. It is obviously not as easily reimbursed as for pumps, but it has also significantly increased over the last 6 to 8 years. So to summarize the results of this sweet registry, more than 50% patients in Europe or the countries where it was studied have used CSI. It is readily available in 20 of the 29 countries where it was done. CGM is at least partially reimbursed in 17 out of 29 countries. So coming to the status in US, the type 1 diabetes exchange. This is another recent publication. They have analyzed data regarding insulin pumps and CGM from 2016 to 2018. Mind you, this data is for all patients, not only children. Patients aging between 1 to 93 years and duration of diabetes being less than 1 to 80 years. So this slide was actually projected a number of times in ISPAE this year, showing that HbA1c has actually worsened over time, even with increasing use of technology. And there is a nice, you can see this age on the x-axis, there is a nice pivotal spurt of HbA1c, which is seen. And it has worsened over time in the last 6 to 8 years when comparing the previous data. So there is use of insulin pump as per type 1 diabetes exchange data has increased from 57% in 2010-2012 to 63% in 2016 to 18 time period. And the largest increase in pump use was obviously in children less than 12 years old. This is regarding the treatment regimen with regards to use of CGM or without CGM. These are the 4 groups. As per the age, in less than 13 years, this dark black bar is only use of MDI. Second is only insulin pump. Third one is MDI with CGM. And this 4th bar is pump with CGM. So you could see that this is only pump with SMBG, does not really help. Even MDI with CGM can have good diabetes control. So CGM is more important than insulin pump. That's the conclusion as per me. Then coming to insulin pump status in India, the options in India are actually very narrow. Only one company provides insulin pump in India. There are 3 models available right now, and the cost is there on the right, which is obviously exorbitant for majority of our patients. Maybe another company is coming with insulin pump in next few months called Ipsomed, and cost may be slightly lesser. The number of insulin pumps being used in India, these are the figures provided by Medtronic database. On paper, there is 4,500 around patients who are using insulin pumps, and of them around 21% are actually type 2, and only around 15% children less than 18 years are actually using insulin pumps. 5 pumps have been given by Kerala government till date to the patients, pediatric patients, and around 102 pumps, around 2.2% are actually reimbursed by the government till date. So actual figures may be slightly more than that. All papers actually may not be on, all patients who are on pump may not be actually on record. So the company believes that actual number could be somewhere between 6,000 to 7,000 of pump users in India. So what are the barriers of adopting pump use in India? So healthcare provider preference, I think, is most important, and this has been proven in the West, that healthcare provider, if they are very conversant with use of insulin pumps, their patients are more likely to get insulin pump prescribed. There are obviously cost, education of the parents, and other socio-demographic factors which can lead to increased or affect the pump use. Barriers in our country, I think, again, physician preference and experience would again be one of the important factors. Physicians' expertise and experience of using pumps in the kids. Obviously, it's difficult to manage patients on pump. We have to teach them a lot. Finance, again, I have highlighted it. That is another important factor, but those who can afford, I think it is easy to prescribe them if they wish to. Social demographic, cultural, I recall one of our patients, parents want the pump, but grandparents did not like it, so they did not go ahead. Although the patient took a trial for a few weeks, liked it, but grandparents were not really happy about their granddaughter having a pump on body. Then obviously there are some commercial and ethical issues involved because it's a costly therapy, and doctors prescribing it may not be looked upon very nicely. So we don't have local data available as well from Indian context to show that these pumps can actually really work in Indian patients as well. Although we have next session, Dr. Swaminathan may be sharing his experience from very poorest of patients in India. There's a large number of variety of pumps actually available for patients in the West, which obviously we do lack, and this could be another barrier. So what could be the strategies for optimal use of this costly therapy? I think we should be choosing our patient really well. It's not that they are just affording it. We have to see whether they can use it efficiently. They can learn the technology, learn how efficiently they can do it, and they are ready to do number of SMBGs, 6 to 8 or 6 to 10 is actually recommended, or they should be using CGM if not continuously, but at least intermittently. Reimbursement could be improved, government could be approached, certification and training of healthcare professionals, proper training on pump use for patients as well, and obviously parents, and we could have some standard pump initiating protocols in place. So coming to our experience, we have a total of around 34 patients, actually more than this, but when we analyzed, the number was 34, around, I think, 8 to 9 months back. So this is data from pediatric and adult endo department in our institute. We have around 25 in pediatric endocrine clinic and rest, I think, 8 to 9 patients from adult endocrine clinic who were less than 18 years. This is our very first patient, actually, who was 11 months old girl. We had to start insulin pump actually out of compulsion, as the parents were both working and grandparents did not give insulin injection. So we started this patient right on insulin pump right at a diagnosis. This child was admitted for us for longer than usual for training them on insulin pump. So apart from 2 kids who were less than 1 year, rest all were more than 10 years of age with mean age of 13.8 years. Mean duration of diabetes at onset of pump therapy was 4.7 years. HbA1c was 10.9 and insulin dose was 1 unit per kg per day on MDI when they were shifted to pump therapy. So hypoglycemia obviously was quite high and frequent, more than 50%. So average duration of pump use in our cohort is around 2 years, 2 months, with a range of 3 months to 3 years, 9 months. And around 28 patients have actually completed 104 weeks, that's 2 years of insulin pump therapy. And this is HbA1c reduction following institution of pump therapy. Over 2 years period, the HbA1c has dropped from 10.9 on MDI to 8.2. There was obviously rapid fall within a year or so, and as expected, it slightly went up. And CGM use in our patients has not been obviously continuous. We try to put them on CGM at least once in 3 to 6 months as per their affordability. And those 7 days of intermittent CGM do guide us really well, particularly on ICRs, ISF, and a lot of dietary patterns which could be identified, and basal patterns can be decided accordingly for further 3 months. Hypoglycemia reduction, as expected, was quite significant. Overall reduction in various types of hypoglycemia was 64%. Lipohypertrophy was decreased significantly. At least 80% of our patients had some degree of lipohypertrophy on MDIs, and it decreased to around 28% on pumps. Insulin dose decreased slightly by 0.1 unit per kg per day. So suggesting a pump initiating protocol, we have actually made a protocol for our unit, which we could discuss, and obviously we are involving on it. So we have to discuss the prerequisites or conditions a patient should meet apart from affording a pump. Then we have to have detailed assessment and counseling of the family by at least 2 consultants in the unit. That's what we try to do. And patient could be hospitalized. In our experience now, we have learned that the patients are doing well if they are hospitalized for 3 to 5 days for initiating insulin pump. And initial insulin dosing has to be calculated by at least 2 persons to avoid any errors. Pump installation has to be properly detailed. And a 3-day structured training module we have developed, what all is to be taught for those 3 days of hospitalization to these kids and families. Thank you. And I'll use this opportunity to welcome you to Chandigarh for next midterm ISPAE meeting, which we have decided the dates to be 7th and 8th of November 2020. Thank you.